هو الموضوع كبير يعني واسع قوي على قد ما قدرت قلت أوضحه يعني وأبين الحاجات اللي ليها علاقة بالأطفال أكتر عشان يبقى بيستفيد. Pediatric CNS infections. First, we have to deal with the modalities for imaging the CNS infection. As everything in pediatric, we start with ultrasound. Why ultrasound? Because it is non-invasive, quick, with no radiation, and available and easy, and can be bedside. But here we have the obstacle that it can be used only until the anterior fontanelle is closed. So it is excellent, quick, and non-invasive modality to assess the ventricular size, especially with patients with post-infectious hydrocephalus. The findings that can be found are intracranial calcification, lenticulostriate vasculopathy, leptomeningeal exudate, infarct, and hemorrhagic foci. Is an example of the thalamostriate vasculopathy. Here you can see the linear appearance, echogenic lines in the basal ganglia and the thalami. And here you can see them in the coronal as punctate areas. These are thalamostriate vasculopathy, and this can be found in torch infection. The differential diagnosis also include Down syndrome, hydrops fetalis, sometimes in hypoxic ischemic encephalopathy. So thalamostriate vasculopathy is an important finding that you you have to do torch screening if you find it. Then we have the extraaxial collections, and you can see here it's very sensitive, the ultrasound, to detect the extraaxial collections. Then we go further to the computed tomography. Without contrast does not provide the diagnostic accuracy. But with intravenous contrast, it detects in the abscess, the bone involvement, the extraaxial empyema, and the leptomeningeal enhancement. But also without contrast, it can be used to detect the hemorrhage, as in herpetic encephalitis, there is hemorrhage. Then we go further for the CT angiography. What is the importance of CT angiography? In children, if there is mycotic aneurysm, in infective endocarditis, and in cardiac patients with shunts, they may have mycotic aneurysm in the brain and present by hemorrhage. To detect them, you can do CT angiography. Also post-infectious arthritis, but it's less common. But the hazards are the radiation exposure, of course, and the limited information of the brain parenchyma. Then we go further for the magnetic resonance imaging with the diagnostic, which is the best diagnostic study, which is a gold standard for detection of CNS infection. And we can add also the diffusion-weighted images, because the diffusion can detect any active infection, any acute insult in the brain. We have diffusion restriction. Also, especially in abscess, and it can differentiate between abscess and TB granuloma. Then we have the post-contrast sequence, which is the most sensitive to detect the CNS infection. It detected the changes within the parenchyma, the extraaxial, and the extracranial compartment also. For example, we have here multiple cerebral abscesses. In T2, it has a peripheral rim, hypointense rim, and internal hyperintense contents and surrounding vasogenic edema. After contrast, you can see that there is a uniform linear enhancement of the periphery, and the content also are non-enhancing. Then we have the true diffusion restriction of the contents. So the true diffusion restriction of the contents is pathognomonic for abscess. So then we come for what are the types of edema. We have many types of edema in the brain. We have the vasogenic edema, which is the most common, and the cause is the disruption of the blood-brain barrier, like in the press, the post-reversible syndrome, which appear in hypertensive patient, and it had posterior and subcortical predilection. Then we have the cytotoxic edema, which is the most commonly known in infarction and ischemia. It is due to intracellular neuronal glial swelling, and the cause is the sodium-potassium pump disruption. Then we have the osmolar increase, which occur in central pontine myelinolysis in electrolyte imbalance. You can see that there is increased osmolarity in the brain and the fluid inside the mind. Then we have the interstitial, which known in transependymal as transependymal CSF permeation, and then myelin vacuolation, which occur in vanishing white matter in Van der Naap disease, where the myelin accumulate fluid. Then lastly, we have here the intramyelinatic edema, which is excitatory edema occurring in the splenium of the corpus callosum, and you can find them in acute case of hypoxic ischemic injury, also in encephalitis, acute case of encephalitis. So in acute cases, you can find this diffusion restriction in the splenium of the corpus callosum. Then we have the MRV. The MRV, especially for venous sinus thrombus. It's important here to note that if you want to do a full examination of MRI for an infection, you have to do the following. MRI, diffusion-weighted images. You have to do SWI to detect the hemorrhage. And then you have to do contrast-enhanced study, and then MRV for detection of venous sinus thrombus. So this is a part of the protocol. So the protocol will be contrast-enhanced MRI, SWI, diffusion-weighted images, and MRV. Then you can do also the magnetic resonance imaging to detect the spinal cord involvement and the nerve root enhancement. We start with the congenital infections because it is the most specific entity of CNS infection in children. We see that the fetus, the congenital infection reaches the fetus through, if it is bacterial, ascending, and most known is the transplacental, the viral, and the parasitic. Then we have the torch infection, and you note that in the first 2 trimesters, if this infection reaches the fetus, it will lead to malformation. But if it reaches it after the complete formation of the brain in the 3rd trimester, destructive lesions and encephalomalacia will appear in the brain. So here we have the example of the congenital infections. We have the cytomegalovirus, the toxoplasmosis, the Zika virus, and the HIV. And here from the diagram, we can see what is the distribution of the disease. Here, cytomegalovirus is known by being microcephalic, so small head size. Also, Zika virus has small head size, so microcephaly in cytomegaloZika, while toxoplasma and HIV, no microcephaly. So microcephaly in cytomegalo and Zika. Then we have the distribution of the calcification. Cytomegalovirus will have calcification around the ventricle directly. Why? Because here the injury is the germinal matrix, which is subependymal in location, and also the vascular insult in the germinal matrix. So the virus will accumulate here, and the calcification will be here closely related to the ventricular area. What about the size of the ventricle? The ventricle, no hydrocephalus, maybe atrophic. Like in this case, this is atrophy, but not hydrocephalic. While the toxoplasma, the normal size of the head and hydrocephalus. So in cytomegalo, microcephaly and atrophy, in toxoplasma, it is completely the contrary. There is hydrocephalus because there is obstruction at the level of aqueductal of sylvius, or also it may be due to secondary to ependymitis, inflammation in the wall of the ventricle. Then we have the scattered and random appearance of the calcification not related to the ventricular wall. Maybe periventricular, but a little bit away. And then we have the subcortical. The Zika virus is known by extreme high microcephaly. So the microcephaly of the Zika is more than the cytomegalovirus. And maybe calcification, and they are random, and maybe also corpus callosum agenus. Which of them have neuronal migrational disorder and cortical dysplasia like lysencephaly and pachygyria? We have the cytomegalo and the Zika more. And the cytomegalo have the most severe one. The Zika may have the cobblestone appearance, lysencephaly, but here we have the lysencephaly of any type. Then the HIV have basal ganglia and parenchymal calcification. The cytomegalovirus, usually the patient complained of hearing loss, sensorineural hearing loss, microcephaly, and the infection of the germinal matrix or the vascular insult, as we have seen. This is the ultrasound appearance with the calcification and the echogenic foci closely related to the brain parenchyma, to the ventricular wall. And also we can see here that there is calcification. And here in T2, we have blooming, T2 gradient, we have blooming periventricular calcification. So the SWI and the T2 star gradient is very important to detect the calcification. Also in cytomegalovirus, we have periventricular fine calcification and cortical malformation, polymicrogyria, anterior temporal cyst, and temporal white matter abnormality. I had a case and just the patient had a mental retardation. It was older patient. And the only finding was the dilatation of the temporal horns of that lateral ventricle and the prominent Virchow-Rubin. Cytomegalovirus also may lead to severe cortical malformation if the infection occurs earlier in the gestational age, like lysencephaly and pachygyria. Also may lead to cerebellar malformation. This is a case that comes complaining of microcephaly. We have done to it ultrasound, and it was closed, the premature closure of the anterior fontanelle. So MRI was done to this patient, and the MRI revealed that there is secondary to, with the microcephaly, there is what is called simplified gyral pattern of the brain. What is the meaning of simplified gyral pattern of the brain? Meaning that there is arrest early in the intrauterine life of the growth of the brain. So here it retains the appearance of the intrauterine fetal brain. So if you have an experience with fetal ultrasound, you see early in the gestational age a simplified gyral pattern, meaning shallower sulci. Okay, so this is called microcephaly with simplified gyral pattern, meaning that it is the same as the intrauterine brain, and it is due to arrest of the growth of the brain early in the intrauterine life, and this means severity of the cytomegalovirus. So this case is called microcephaly with simplified gyral pattern. Is the torch the only cause of microcephaly with simplified gyral pattern? No. We have two entities. One of them is genetic. genetic related, and the other one is TORCH. So whenever you find microcephaly with simplified viral pattern, you have to do TORCH screening. And if it is negative, it may be related to chromosomal aberration and it is genetic. Then we have the congenital toxoplasmosis. We have changes in the eyes, and it is important to note that there is changes in the eye in the congenital toxoplasmosis. And the key differentiating from the cytomegalo, it's the normo or the macrocephaly due to the hydrocephaly. Then the scattered chunk calcification, cortical, subcortical, periventricular, basal ganglia. The cortical dysplasia here is less common. The hydrocephalus is due to epididymitis or aqueductal obstruction. Then we have the congenital Zika, and we have noted that the severe microcephaly is the congenital Zika virus, and there is callosal malformation and also cortical dysplasia with cobblestone malformation. It is cobblestone type of lysencephaly. It is different, it has serrated outline. Then we have the ventriculomegaly. Congenital and neonatal herpes simplex virus. The herpes differ from the older one. The congenital herpes differ and neonatal and differ from the older children. In older children is more likely to occur like in the adult, in the insula and temporal lobe and limbic system begin there. But in the congenital and neonatal herpes virus, there is less insula and temporal lobe limbic system affection. There is cerebral edema, diffusion restriction areas in the brain, hemorrhage, leptomeningeal enhancement. Why there is diffuse affection in the brain in the congenital herpes simplex? This is due to that spread inside the brain, it's hematogenous spread, not through the nerve as in the adult and in the older infants and children. This is an example of after the healing of the herpes simplex virus. So this case will come too much to us. It has extensive encephalomalacia. So when you find extensive encephalomalacia in the brain like this one and the other one, you have to suggest the presence of congenital herpes infection. Okay? Suggest the presence of congenital herpes simplex virus. Also, it may be due to hypoxic ischemic insult healing, but it's not that extensive. Okay, so in extensive encephalomalacia everywhere and white matter damage usually suggest herpes simplex virus. Then we have the herpes simplex virus appearance in older children. We note that it is like the adult. It begins in the temporal lobes. Okay, as we see here, there is swelling in the temporal lobes. Okay, and when you go do a contrast enhanced study, there is enhancement in the temporal lobe. So the temporal lobe and the insula are pathognomonic for herpes simplex. You have to suggest that that this is herpes. Why? You have to, whenever you doubt that this is herpes, you have to suggest for the clinician that this may be a herpes simplex virus infection, because the treatment is very simple for them. They give Zovirax, and if it left the patient without treatment, this may be devastated results. Okay, so when you suspect herpes simplex virus infection, you have to report it to the clinician, and he may give also Zovirax without positive virus in the CSF. Why? Because sometimes the CSF analysis for the herpes become negative. There is false negative. So he had to give blindly the Zovirax whenever you suggest the herpes infection. So when you found that the temporal lobes is affected, there is enhancement, there is hemorrhage, like in this one, okay? you may suspect the presence of Herpes simplex virus infection. And this is after healing by encephalomalacia. You can see that this is during the acute phase, and this is after healing by extensive encephalomalacia. Okay? And it's important to note that you have to, whenever you have a CNS infection, you have to deal with the CSF analysis. Okay? You have to be oriented with the CSF analysis. The CSF analysis, if there is a bacterial infection, there is much cells and they are polymorph. If there is, it is cellular, hypercellular with polymorph. If there is viral infection, it is hypercellular, but they are lymphocytes. This is very important. If it is autoimmune, there is increased protein, but no cells. Okay, so this is very important for the radiologist to take it into consideration. Then we have the other viral infection. What is specific about them? The Epstein-Barr love the deep gray matter, like in this case. Taban, it's not diagnostic, but you don't have to be sure what is the diagnosis of this case, but we have the enterovirus. Important in the enterovirus, when you found cord gray matter affection, maybe there is an enterovirus infection. This is the important one, because when we found the gray matter affected in the cord, usually we suggest an autoimmune or a demyelination or something like that. But no, you have to note that enterovirus have the same appearance. They affect the gray matter of the cord. If the patient is coming with flaccid paralysis and fever, maybe have enterovirus. They have to do lab diagnosis for enterovirus to be sure before diagnosing that it is autoimmune. Then we have the influenza and the COVID, and we have the very well-known acute necrotizing encephalopathy. And we have cerebralitis. This case, we have the cerebralitis. Cerebralitis here appear like a pseudo-tumor. Okay, so you may suspect that there is a tumor here. So the follow-up is very important for this case. If this infection, and this is the acute phase, it will change and heal by gliosis. But if it is a tumor, it will remain the same or increase in size. So here you can do the follow-up, and also you can do MR spectroscopy if there is a marked increase in the choline. It may be a tumor, and if it is choline mildly elevated, more with infection. We have the acute necrotizing encephalopathy, which was very eminent, and it appears during the COVID acute first episode of the acute affection of the COVID during 2019. All these cases were diagnosed during 2019, and all these cases were diagnosed as acute necrotizing encephalopathy, and they were referred to the pediatrician to do a swab from the throat, and it was negative for influenza. So this was weird for us. Why this case in the radiology and in literature, it is related to influenza virus. But after that, they reported that COVID also can have the acute necrotizing encephalopathy. How to diagnose acute necrotizing encephalopathy? Bilateral thalamic hemorrhagic lesions. Also, the hemorrhagic lesion will have the insula and the temporal lobe, and they have the infratentorial affection also, and hemorrhage and edema, and it healed also by gliosis. So these different cases of acute necrotizing encephalopathy, and this case in the chronic case after healing. And this is an example also of other causes of encephalitis. We have here the malaria. So we have areas of diffusion restriction deep in the white matter. And here you can see subcortical in the white matter. So all these cases, there is diffusion restriction, only the diffusion restriction in the white matter, in the malaria. And here we have the excitatory edema in the corpus callosum, as we have reported that this appears in acute encephalitis and also acute hypoxic ischemic injury. Take care of the differential diagnosis. So if you are guided by the CSF, you may diagnose the patient by if he has protein, high protein and no cell, it may be autoimmune or demyelination. If the ACSF is normal, you may consider also the PRES and the metabolic disease. Then we have the bacterial infections, which is more easy in radiology to diagnose. It may appear as meningitis, cerebritis, extraaxial collections, epididymitis, ventriculitis, and hydrocephalus, abscess, thrombosis, vasculitis, and infarct. To be able to diagnose all of these, you have to do contrast-enhanced MRI with SWI, with diffusion-weighted images, and with MRV. This is a case of meningitis. You can see here that there is increased signal. This is a flare. There is increased signal in the sulci. And after contrast administration, there is leptomeningeal enhancement, diffuse. Then another case of meningitis, you can see here there is enhancement in the sulci and in the base of the brain. Cerebritis and abscess formation. Cerebritis, he may have a diffusion restriction and heterogeneous areas of enhancement. And if there is breaking down and peripheral uniform thin rim of enhancement, this is abscess, okay? Note that if you do for cerebral abscess, also the SWI will have this appearance, which is called dual rim sign, and this is pathognomonic for abscess. So in abscess, we have a low T1 and high T2 with a peripheral limb of low T2, and then we have a peripheral uniform enhancement, ring enhancement, and then we have here a true diffusion restriction of the contents. Extraaxial collections may be subdural, like this one, with peripheral enhancement and thickening of the meninges. Then don't forget, when you find ventriculitis, the ultrasound is important for diagnosis and the follow-up, and also to detect the hydrocephalus, and maybe the complication of shunt. The ventriculitis may be complication of shunt insertion. We have echogenic wall like this one, thickened echogenic wall with intraventricular echoes, and maybe subdural, extradural, subdural collections and empyema with inside echoes. Then another example of ventriculitis, we have here enhancement in the ventricular wall, and after healing, healed by obstruction and the fibrosis, and the patient had hydrocephalus, obstructive hydrocephalus after healing. The complications are important. Why? Because they are common. When you have severe infection in the brain, you may have cerebral venous sinus thrombosis, like this one and this one. And also you may have infarctions. Why infarctions? Because the small vessels penetrating into the area of the basal ganglia and the thalami, they are penetrating vessels. These arteries may have deposition of the infectious material and vasculopathy and may be plugged. Okay, so this may lead to acute infarctions. Here you can see in diffusion, there is acute infarctions in the basal ganglia. So usually this is the area where the infarctions occurs. What about the tuberculosis? In tuberculosis, we have pachymeningitis and also a characteristic appearance of the tuberculoma. What is the characteristic appearance of the tuberculoma? It has a characteristic low T2 appearance. So when you see an abscess, it has a high T2, internal contents, high T2. But here all the granuloma is low in T2. So this is important. And then we have the same pattern of enhancement, is peripheral enhancement, but it is facilitated, no diffusion restriction. In tuberculoma, it is facilitated. Then we have also the increase, the contents, caseous material accumulating in the base of the brain, and they are enhancing. And this is characteristic. Can see here the accumulation of the tuberculous material and the extensive enhancement at the base of the brain. Then we have the meninges. They are filled with caseous material, and the appearance of the caseous material is low T2. So low T2 is characteristic for tuberculoma and for detection of the caseous material. And it also has a rim and linear enhancement. And this is an interesting case that came to our department, and the patient was complaining of long history of low-grade fever and increase in headache, severe headache, and he has done CSF to assess the puncture and assess of the CSF pressure, and it was high. So he was referred to do different radiological investigation. He has done MRI, brain and spine with contrast. Okay, and then the clinician came and told me that the patient has a long duration on antibiotic, and he's not improving. He's still complaining of these vague symptoms for 6 months at least. And this was the MR of this patient. You can see here that there is extraaxial widening, separating the cerebellar folia from each other. And you can see here also there is pseudocyst, which is called gelatinous pseudocyst. What are the gelatinous pseudocysts? Or are extraaxial areas surrounding the Verkau-Ruben. They accumulate gelatinous material, and they are called gelatinous pseudocysts. This is a typical appearance. Okay, like enlarged Verkau-Ruben, but they are very characteristic that they have wall. You can see their walls. It was very bizarre case. So we suggest that it may be a cryptococcosis, which is fungal infection. And this is the case from the literature. It is the same as ours, but ours is more, eminent. Okay. And they give the patient antifungal treatment, and he responds very well for the antifungal treatment. Another case, we will now discuss the spinal and cord infection. Very important, at least in Egypt, is the TB. We have the Pox disease. Here we can see that there is fracture of the bone and without affection of the disc, and there is epidural anterior spinal sheet of caseous material, and we have epidural abscess also encroaching on the spinal cord. And upon contrast enhancement, contrast administration, there is enhancement of all of these. So it is an epidural abscess, and maybe there is also a cold abscess, and maybe there is psoas abscess in this case. So this Pox disease, very important, at least in Egypt. Then we have another spinal infection. Maybe there is osteomyelitis and extension of the infection into the spinal canal. So here we can see that there is epidural abscess, secondary to osteomyelitis, and compressing the cord. Don't forget about the granulomatous disease of the childhood. Why? Because this is a disease characteristic for the childhood. Lately, we have been dealing with in the pediatric age group with the immunodeficiency diseases, and now they are doing much work in immunology and in gene to diagnose and separate them into a very wide variety. And among them, we have the granulomatous disease, which is the first one to be diagnosed, an older diagnosis, but it's very common in children. It is rare genetic immunodeficiency, but we have seen it a lot. What is the problem with this case? The problem is that the phagocytes are unable to deal with the staph. So the staph, the staphylococcal bacteria, it is eliminated very easily in a normal child, and a pus is formed after the phagocyte engulfs it. But in this patients having granulomatous disease of the childhood, the phagocyte cannot engulf the staph. Okay, and this leads to a severe affection. Usually, the patient first complaining of severe chest infection, like in this case, and then he may have also a spinal cord or bone infection, osteomyelitis, and epidural abscesses. Okay. So now we finish. So the take-home message of this lesson is that the CNS infection is a broad entity in children, and take care of the specific changes related to the pediatric age group and its differential diagnosis. So depend on the CSF analysis. We have to pick the best radiological modality needed to reach the diagnosis, and don't underestimate the importance of the ultrasound if the fontanelle is still open, and then use the gold standard, which is the MRI, and if there is hemorrhage, you can do a CT. Thank you.